so far, which largely explores the impacts of sociostructural determinants on substance use and negative health outcomes among marginalized communities. Specifically, she examines polysubstance use-related mortality through interdisciplinary research that incorporates drug use epi, structural equation modeling, and machine learning techniques. During the first year of her postdoc here at Mailman, she was a recipient of the 2024 Data Science Seed Fund, co-recipient of the APHA 2024 New Investigator Award, and awarded a NIDA-funded loan repayment program. Additionally, we're really excited about the fact that she received a very promising score of 20 in the 3 percentile range on her KO1 application. I'm really pleased to welcome you here, and I'm really looking forward to your talk.
Thank you. And thank you so much, everyone, for coming to my talk. It is a pleasure to be presenting some of my work in front of all of you today. The title of my presentation today is Polysubstance Use and Public Health, Insights, Challenges, and Opportunities for Action. So I'm going to start, in terms of my outline for today, I'm going to start a little bit about telling you about the overdose epidemic, and then I'll tell you a little bit about me. Then I'll talk about 3 distinct research studies that I've been leading and been a part of. And then towards the end of the presentation, I'll focus a little bit more in terms of mentorship and my philosophy around teaching. And then we'll end with like my career next steps and questions from the audience. So a little bit of background, the overdose crisis in the United States. What we see is that the United States is internationally unique when it comes to high rates of drug-related morbidity, so thinking about HIV, HCV, and non-fatal overdose, as well as mortality, including fatal overdose over the years. And so many of you guys probably seen some form of this image in some fashion. So this is one of the iterations where we see that the opioid overdose epidemic has unfolded through 4 distinct waves, spanning across the past 22, like I would say 20 years, so 2 decades, right? Starting in the late of 1990s, we saw that a marked rise in prescription opioid overdose, which transitioned to an increased rise of heroin around 2010. And then around 2013, we saw this specifically this exponential increase relating to fentanyl and fentanyl-related analogs. And so now around I would say like around 2016, 2017, we saw within the literature that now we've entered into what is considered the 4th wave, which is characterized by polysubstance use, but mostly around fentanyl and psychostimulant co-use. So thinking about fentanyl and methamphetamine that we're seeing more on the Northeast region of the United States, or fentanyl with like cocaine more in the Northeast region of the United States. And so when we see, and this graph right here is showing like overdose deaths by fentanyl and stimulant presence from 2010 to 2021, we see that the rate of fentanyl overdose has increased. From 2010, it was, if you're focusing on the purple bar, in 2010, it was fentanyl with stimulant was present among overdose deaths only at 0.6%. But by 2021, we saw that it had increased to 32.3% of overdose deaths had the presence of fentanyl with a stimulant in it. So again, we're seeing this increase in this polysubstance use narrative. And so also to put this into context, we see that between 2019 and 2023, more than 250,000 people died of a fentanyl-related overdose. And we also see that if we take a look back and just put it within context, we see that the fentanyl has killed more Americans than the wars in Vietnam, Iraq, and Afghanistan combined. So it means we've, at this point by 2022, for the first time in the past 20 years, it was the first time that we saw that we reached the 6-figure in this crisis, where more than 100 people died of an overdose. So from 1999 to 2024, we lost 1 million lives. Over 1 million lives that were preventable deaths died to the overdose crisis. And so we've all seen the headlines, right? Like we've seen how the headlines noted the overdose crisis is lowering American life expectancy and influencing the nation's politics. But sometimes it feels like we are oftentimes become desensitized to these numbers, right? And maybe it's compassion fatigue, or from a researcher's perspective, we're so used to seeing numbers that I think it's really important to realize that these numbers represent preventable lives, right? That were lost way too quickly and were cut short unnecessarily. Because that million figure represents mothers, fathers, It represents brothers and sisters and friends, cousins, loved ones. People cared about them and their lives meant something. And among the million lives lost was my brother, who left us too early in 2015. He was the kindest and goofiest person you would have ever met, to be honest. He lost my 8-year-old niece in April 2025, and later, 6 months later, we lost him to a fatal overdose. And so for a very long time, I was really confused about why his life was cut so short. And also seeing the narrative around overdose, seeing these stigmatizing titles, right? People calling, people who died of overdose, calling them junkies, calling them addicts, seeing, talking about being a drug abuser. And I was really confused because that wasn't my brother. My brother wasn't an addict. He wasn't a junkie. And so he played for like the national softball team and he was really good, right? And so I wanted his death to matter to me. So I embarked on a journey to become a substance use epidemiologist because I wanted to make sure that we did something about it from a population standpoint. And so I went on this academic journey. And so it started by getting a few degrees. So I got my bachelor's at Drexel and then went on. I was born and raised here in New York City. So my family was like really excited for me to come back to New York for my master's in public health at the CUNY School of Public Health. Then I left them again. I was like, okay, I'm going to Baltimore for my PhD. And then I decided to come back home to Columbia here, where I'm currently in my 2nd year of my postdoc amongst all of you amazing people. And so altogether, my work can be summarized by this mission statement that I have here. And throughout this talk, I'm gonna come back to this mission statement as I'm gonna use it to anchor and center my talk overall. But my mission statement is to advance scientific understanding of polysubstance use by examining its individual, social, and structural determinants with the goal of informing evidence-based prevention, intervention, and policy strategies to reduce associated harms, promote health equity, and improve outcomes for vulnerable populations. And so this is just a visual depiction of what I just said, right? A lot of my work focuses on examining individual and structural determinants of polysubstance use across varying marginalized populations. And so I leverage latent variable modeling in a lot of my work, and more recently, data science and spatial analyses as well, to see how these individual and structural determinants related to adverse outcomes such as HIV, HCV, and non-fatal overdose, as well as drug poisonings as well, so fatal overdoses as well. And so I've been throwing this term around, polysubstance use. So before I move on, I'm going to take a little moment to define what do I mean by the term polysubstance use so that we're all on the same page. So polysubstance use refers to the use of 2 or more substances, either intentionally or unintentionally. So when we say intentionally, maybe someone decides to use 2 different substances around the same time so that they can experience some synergistic effect of the particular drug. But unintentionally, someone may buy a product, right? But then it might be adulterated with fentanyl or xylazine. And so this in sequence would lead to like an unintentional harmful effect. And so timing is also very important when we think of polysubstance use. So you can think of polysubstance use concurrently, so within a specified time frame. And usually within the literature, we see that's captured like daily, monthly, or lifetime, which I am not a proponent of that, but we can talk about that later. Or it could be in terms of sequential. So someone uses one substance and then later on they use one after the other. We also see that it could be used in this simultaneous fashion. So think about someone is at a party, maybe they're smoking marijuana and they're drinking alcohol. And mixed fashion is another term that we've seen come up in the literature. And sometimes it's used to kind of capture this like at the same time administration. So think about maybe goofballing, which is the administration of a bolus of maybe a fentanyl with a methamphetamine at the same time so that they can experience some synergistic effects. So 3 key components in defining polysubstance use is the number of substances used together, thinking about the timing as well as the intent. So in my first year of my postdoc, I really wanted to go on and try to explore some of these, different like polysubstance use typology. And so I applied for the Data Science Institute seed funding, where I am using natural language processing to understand how people talk about their co-use or their polysubstance use on social media. I also applied and I was the co-recipient of the National Violent Death Reporting System, the new APHA's new investigator research award, where I'm currently looking at different typologies of polysubstance use among suicide decedents using the NVDRS. And the NIH loan repayment is just helping me pay all of the loans that I've accumulated over the years. And so I also, towards the end of my first year, I applied for the K01 award, and I was very excited that on my first try, I was able to score 20, which is amongst the 30th percentile, but I'll talk a little bit more about this towards the end of the presentation. So a lot of my work is rooted in using like the Rhodes risk environment framework to understand how different social contextual factors are, in a sense, are associated with polysubstance use. And so the risk environment model by Dr. Tim Rhodes, it really helps us unpack, right, some of these different levels at the micro and macro level and how they influence different dimensions of our society, whether it's at the social, economic, or as well as physical and policy level. And also, I also pair that also with like the intersectionality framework, where Dr. Kimberly Crenshaw, who is in our law school here at Columbia, she first coined this term so that she could understand how Black women experience oppression from these two distinct kind of axes, right? From sexism as well as racism. So understanding that in terms of the intersectionality framework, oftentimes we look at race and sex as these two different constructs, right? Maybe we'll include them in a model so that we can, adjust for them as a covariate between an exposure and an outcome. But oftentimes, and in our lived experiences, our sex and our race are inextricably intertwined. And so I wanted to apply this framing to substance use to understand some of the more recent trends of the drug poisoning that we've been seeing more recently. And so just as promised, we're back to my mission statement. And I really wanted to see how to leverage, the intersectionality framework to promote health equity, especially among vulnerable populations. So this will lead me to talk a little bit about the first study, which is the overdose crisis and intersectionality. So according to recent analysis from the CDC Wonder database, we see that back in 2020, Black Americans for the first time had greater death rate from opioids than their white American counterparts. And mind you, when we think about even in terms of sex, this graph right here is showing the age-adjusted rate of drug overdose deaths per 100,000 people in the United States from 2002 to 2022, broken down by sex. And so we see that drug overdose death rates have been consistently higher for males compared to their female counterparts across the past 2 decades. And so to get a better picture of the overdose crisis, we use data from the unintentional drug poisoning fatality data from 2010 to 2022 from the CDC WHISKERS. So for that acronym stands for Web-Based Injury Statistics, Query, and Reporting System, where they classify these deaths based on the ICD-10 codes. And so here in this figure, we see that mortality rates for Black men have surpassed their white male counterparts in 2016. And we see that Black females surpassed their white female counterparts back in 2019, which indicates, again, like we're seeing these intersectional health disparities across drug poisonings. And so we're interested in seeing how do Black males, Black females, and white females compare to their white male reference group in these age-adjusted drug mortality. And here we see that the mortality ratio, and I'm gonna just so we see that by 2020, we see the mortality rate for Black males were nearly 60% higher than their white males. And also we see that rates for white and Black females, even though they're lower than their white males, we do see that for Black females, it is increasing past, I would say starting from around 2016, even though for white females, we see that a decline over time compared to their white male counterparts. So this scatter plot is showing you the comparison of years of life lost and inequities between white males as the reference group and comparing Black males across all the 50 United States. And so to kind of orient you to this graph right here, we see on the upper right quadrant represents the high years life lost, high inequity. And so here we see when we're looking at Black males, we see that there's certain states here that are of concern, where we see high inequity and high years life loss for Black males, including Ohio, Pennsylvania, Missouri, Wisconsin, which are denoted, if you look into the literature, these are like some of the Rust Belt states, right? Where we also saw some high deaths of despair as well. So these states may reflect either some systemic disparities, whether that is in terms of healthcare, access, or social determinants of health, or in economic inequalities. So this figure is showing, comparing white males to the Black female population across the 50 states. And again, if we're looking in terms of inequity, we see that West Virginia has high inequity despite low absolute years life loss, where we also see areas in the lower right quadrant, states like California, Pennsylvania, Texas, Illinois, Michigan. We see that these states are among the 19 states with high absolute years life loss for Black females. But even though we do see this low relative disparity, suggesting maybe more of like a societal burden rather than like any race-specific inequities. And comparing white females to their white male counterparts, we see that white females experience higher years of life loss in sex-related disparity in West Virginia compared to their white male counterparts. But still, at the bottom right quadrant, we do see that overall, we see like states like Ohio, Pennsylvania, California, as well as like Florida, are among the highest with absolute years life loss states, but with relatively low inequities. So some key takeaways from this particular study was it really indicates that we do need to take more of an intersectional approach to our research, especially thinking about the overdose crisis. And so we saw that when we took that intersectional lens, that the disparity did not start in 2010, right? But actually started a little bit earlier, especially for Black men, when we saw that Black males surpassed their white male counterparts back in 2016, and white females surpassed their white female counterparts back in 2019. And so just thinking just in generally as well, thinking about some of the states that we may want to do some further research on is like Ohio, Pennsylvania, Missouri, Wisconsin, especially in these areas where we see higher burdens of drug poisoning, especially amongst Black males. And so again, these findings emphasize the need for taking more of an intersectional lens, especially when we think about the overdose landscape. A lot of my recent work has also focused on understanding typologies of polysubstance use as well, and looking at how they're related to adverse harmful outcomes, and which leads us to the next study. So this study focused on, like I said earlier, this study focused on polysubstance use and how it was related to different outcomes of HIV, HCV, and non-fatal overdose. And for this particular one, we focus among people who inject drugs. So one of the populations that is at most risk for drug-related morbidity and mortality is people who inject drugs, or you'll often hear me use the acronym PWID throughout this presentation, where we see that currently we have 6.5 million Americans who inject drugs across our nation. And based on the literature, we see that PWID are at the highest risk of fatal and non-fatal overdose, with 21% reporting experiencing a non-fatal overdose in the past 12 months. 42% had a non-fatal overdose in their lifetime, and 25% of the overdose deaths are among people who inject drugs. The burden of HIV and hepatitis C infection is also pretty considerable amongst this population, with an estimated 1 in 3 HCV deaths are attributable to injecting drug use, and 1 in 10 new HIV diagnoses are amongst PWID. And we also see amongst these populations that there are different motivations for engaging in polysubstance use as well. So here I have 2 salient quotes from a recent qualitative, well, recent is maybe not the right term because it was back in 2020, but it's still a really great paper by Pablo Valente and Katie Biello, where they examined the patterns, context, and motivation of polysubstance use among PWID in the Northeast region of the United States. And so here we see one of the participants talk about using polysubstance use to manage the come down effect. So this person said, I would smoke crack and use heroin or fentanyl, what we call landing gear, to come back down. And once you get down, then you'll want to take another hit of crack to go back up. we see another motivation is to experience, again, like the synergistic of drug effects. So we see this participant that because the heroin is not that good or pure, actually, because it's not even heroin, it's contaminated. So people try to make it stronger. And that's one way that maybe you can make it stronger. Just by putting or mixing cocaine, you can actually make the shot stronger. And so we really wanted to characterize the typologies of polysubstance use and see how different profiles were associated with maybe increased risk of non-fatal overdose, HIV, and HCV. And so for this data, it came from the CDC's National HIV Behavior Surveillance System, which is a biobehavior surveillance among people at increased risk for HIV infection. And so the CDC works with multiple different subpopulations that are at increased risk for HIV. And so for the purpose of this work, we focus on PWID, the 2018 cycle. And so for this study, I ran a 3-step maximum likelihood approach latent class analysis, where I included 8 different substance use indicators that was divided by injection and non-injection route of administration. So I included cannabis, opioid, cocaine, and methamphetamine injection, as well as opioid, cocaine, methamphetamine non-injection, as well as benzodiazepine non-injection. And then we looked at the distal outcomes of HIV status, lifetime HCV, as well as non-fatal overdose while controlling for these micro-level covariates. And so the results of this project is showed 4 salient classes of both a monosubstance as well as 3 polysubstance use classes. We saw that most of the sample fell within like the opioid only injection class, which is class number 1. But we also saw like there was a minority of a subpopulation that endorsed almost all of the different drug indicators. So we termed that the polydrug polyroute indicator, a drug class. But then we also had these 2 opioid stimulant polysubstance use classes. One was called cocaine dominant polyroute and the other one was meth dominant polyroute class. And so after running pairwise comparison for mean differences for all 3 distal outcomes by latent classes and adjusting for the pertinent covariates, we see here, and the brackets indicate statistical significance. We see that the polydrug polyroute class had the highest proportion of non-fatal overdose, followed by the cocaine dominant, meth dominant class as well. And so like the opioid only, the monosubstance use class had the smallest proportion of non-fatal overdose. But when we go to like the next 2 panels looking at HIV and HCV, we actually see that the opioid only injection class had a higher proportion of people who inject drugs who tested positive for HIV than all of the other polysubstance use classes. And finally, we also see that the opioid only, the monosubstance use class actually had greater proportion of HCV lifetime status compared to the polydrug polyroute as well as the cocaine dominant polyroute class as well. So this study is currently is under CDC clearance right now. It's going as like the final second round because it had to go to 2 different departments. But the key takeaways, I've been so fortunate to be able to work with my CDC collaborators and select key takeaways are that these results show that there are these salient patterns, right, in combinations of polysubstance use across, especially people who inject drugs, and they do have differential impact on risk, like, especially when we think of HIV, HCV, and the ongoing overdose crisis. And then also, when we think about, especially with overdose crisis, we can see that the different combinations of multiple drugs may increase one's risk of an overdose risk. And so, but we also saw that people who inject drugs in the opioid only injection class had higher proportion of HIV and HCV compared to their polysubstance use class counterparts. And so future studies need to kind of understand some of these, not only behavioral differences, but to think about some of these structural drivers that might be why we're seeing some of these salient differences as well. So within the context of the overdose crisis, it's also, like I said, important to consider social and structural determinants of overdose risk. And so I'm really excited that we have evolved from when we think about like the decades of when the inception of epidemiology, right? We've really evolved in our basic understanding of disease processes to acknowledge that many of these diseases, especially when we think about exposures and outcome, are not done in these like vacuum, but they're within the context of the environment and the social structural factors. So for the next study that I'm going to talk about, I really focus on understanding how residential segregation and income inequality were associated with different profiles of polysubstance use risk across Chicago. Which takes us to the last study that I'm going to focus on for today. So you're probably thinking, okay, that's random. Why Chicago? Well, in 2022, there were more opioid-related overdose deaths in Chicago than homicides and traffic crash fatalities combined. And we see that 65% of these fatalities were among non-Hispanic Black individuals, as well as 70% were among men. And we see that the opioid-related overdose deaths are one of the primary drivers of life expectancy gap between Black and non-Black Chicagoans. Hope I'm saying that right. From a New Yorker, if anyone's from Chicago, I'm sorry. But we see that in 2017, the gap was about 8.8 years, but by 2021, we saw that it had increased to 12.7 years. And so my collaborators over at Penn and I and some of my collaborators here at Columbia, we were interested in understanding some of the census tract level polysubstance use typologies to explore the relationship between the clusters of polysubstance use at the census tract level and some of the contextual determinants as well among people who died of an overdose from 2017 to 2022. And so we use data from the medical examiner's toxicology report, which included like demographic information, as well as street addresses of where the actual overdose injuries actually occurred. And so we use latent profile analysis and at the census tract and use multinomial logistic regression as well. And each of our late LPA indicators were these substance use indicators rate per 1,000 residents since it's at the census tract. And so we included alcohol, benzo, cocaine, fentanyl, heroin, methamphetamine, prescription opioid, xylazine, and other drugs as well. And from our social contextual factors within our model, we included neighborhood deprivation, population density, median household income, as well as racial isolation index, particularly Black isolation index. And so here, if you look at, for example, just the neighborhood deprivation as well as the racial Black isolation index, we see the distribution of these factors. And you can notice that like in the areas where you see higher racial isolation, we also see the more of the yellow, which indicates like the most deprivation census tracts as well. And so after running our LPA model and looking at fit statistics such as the AIC, BIC, the entropy, and looking at substantive knowledge, we came up with a 3-cluster model where we saw this kind of like low polysubstance use, moderate polysubstance use, and high polysubstance use rate as well, where most of the census tracts were in fact amongst the low polysubstance use but we still had approximately 18.8% of the census tracts which fell within this high polysubstance use cluster. And so here I just like mapped it out to visually see it. And so just visually speaking, right? Like we see that the high polysubstance use census tracts appear to be more prevalent among the census tracts with higher neighborhood deprivation and Black populations as well. So we ran a multinomial logistic regression. And what we see in the unadjusted model is that we see that cluster 2 and cluster 3, which are the moderate and high polysubstance use compared to their low polysubstance use referent cluster, we see that they are more likely to be amongst census tracts that have higher deprivation. And we also see census tracts that have increasing Black isolation or residential segregation were more likely to be members of the moderate or the high polysubstance use clusters compared to their low polysubstance use cluster referent group. But we also see that as median household income increased by every $10,000, right? Like these census tracts were actually less likely to be members of the moderate or high polysubstance use clusters as well. So, and even in the adjusted models, we see that these relationships are attenuated, but not completely washed out, where we still see that the Black isolation is still significantly associated with moderate and high polysubstance use clusters. And we see that increasing median household incomes at the census tract level does indicate that they're more likely to be members of less likely to be members of the moderate and high polysubstance use clusters compared to their reference group. I mean, this work is still in progress, and we do plan on looking more in terms of looking at spatial autocorrelation and possibly adding a spatial lag, but this is what we see so far, as that this does seem to indicate some regionality when it comes to polysubstance use, especially at the census tract level. And so by understanding areas where we might need to maybe provide more outreach, right? Whether that is providing these areas with the high polysubstance use with increased vending machines, right? With harm reduction materials like naloxone, or even thinking about how future studies can and should continue to focus on like the special trends when it comes to polysubstance use, so that we can know where to best place our resources. So I do plan to extend these lines of research and work, and just a glimpse into my future. I plan on continuing a lot of the cross-institutional collaborations that I've already put in place. I'm planning on to continue to work with my great collaborators here at Columbia, as well as Hopkins and NYU. For example, I'm currently working with Dr. Piamato and Dr. Sylvia Martins on leveraging the TEDS dataset, which is the treatment episode dataset, to examine polysubstance use and treatment outcomes. But I plan on continuing my work with Dr. Amanda Bunting, as well as Dr. Joy Palomar at NYU, where we're using, like, for example, with Dr. Bunting, leveraging social media and to look at polysubstance use. So she is working on my DSI grant with me, but also seeing if we can use the Caesar data with my great CETA fellow postdocs in the back as well, to do some amazing work as well within that space. I plan on continuing working with Dr. Smith and Dr. Uzi at Hopkins to examine structural determinants of health and overdose risk, as well as I'm collaborating with Dr. Morrison on a study where we're going to be leveraging the mortality data to look at opioid stimulant polysubstance use and residential segregation as well. But I also have a lot of my previous mentors, Dr. Linton and Dr. Johnson, that we're finalizing a lot of the work amongst people who inject drugs right now with the CDC data. And I also plan on continuing my collaborations with the Data Science Institute, such as Dr. Murasan and Dr. Kristofsky, who are my collaborators on the DSI project as well. I know I don't have data to show yet, it's still in progress, but if you invite me again, I can tell you a little bit more about that. But also I have my LRP mentor, Dr. Duncan, and my fantastic KOL mentorship team, such as Dr. Ayalo, Dr. Stingone within the department, as well as Dr. Musi from Hopkins, Dr. Tab from Drexel, and Dr. Meacham from UCSF. So I realized that by taking a cross-institutional perspective, we can really make some of these impactful changes, because a lot of times people work within just their departments, right? But then we all share the same knowledge and thoughts, but by expanding the collaborations, we're able to get diverse perspectives as well. Especially, like, for example, Dr. Meacham is over at UCSF, and we see that the typologies are a little bit different over there compared to the Northeast region. But I'm also excited about my new collaborations as well, extending a lot of my body of work to examine, for example, overdose, mental health, and suicide with Dr. Carrie Keyes, leveraging natural language processing to understand mental health and police violence with Dr. John Pemplin, and expanding my work to maybe explore overdose risk and climate change that I've talked recently with Dr. Pam Lidbeck as well. So hopefully we get to submit that grant in 2025. But I also have my amazing collaborators and fellow CETA fellows as well that we've been working on. So for example, we're right now working on leveraging the seizure data with Joy Palomar to look at spatial temporal trends in fentanyl pills at the county level, but also working with Dr. Morrison to see if we can look at residential segregation and opioid stimulant polysubstance use with the new mortality data as well. So all of my current body of work, I've talked a little bit about the work that I'm currently doing and the work that I'm doing now and the work I plan on doing, but all of them focus on, like, I always go back to like the so what question, right? Like, yes, I know personally why I'm doing this, but what impact does it have for our population, right? And so trying to orient my work and thinking about bodies of solutions, or just to think about a way forward. Again, like, I think about the necessity to leverage intersectionality theories, right? So because we know that race, sex, socioeconomic status, they're all, by creating interventions at the intersection of these different identities can produce more of an impactful impact when we think of outreach, but also think about harm reduction services and expanding harm reduction services where they're needed by leveraging spatial analyses as well. And also thinking about economic investment. So how can our work inform increasing funding for education or job training, right? Or community development, and increasing access to treatment as well, maybe in the form of mobile health clinics or telehealth service. But one of the buckets that I've been particularly interested in is connecting with policymakers and to discuss these actionable change when it comes to by leveraging our scientific evidence. And so 2 months ago, I was very excited to lead the policy recommendation workshop at the Polysubstance Use Symposium this year at NYU. And so Dr. Bunting and I are scheduled to present our findings to the Pew Trust Charitable in this upcoming January 2025. But we ended up having a great workshop where we had policymakers in the room, which is oftentimes rare, right? But also community leaders as well as researchers. And so this is just like a word cloud of the policy recommendations that came out of this workshop, where we see, but really a lot of folks talked about increasing funding, right? And thinking about billable harm reduction services, policy changes around methadone dispensing, and funding overdose prevention centers, similar to what we have here in New York, but also opening them in different regions of the United States where they're most needed as well. And part in the room was also Dr. Cunningham, who is the New York State Senate, the commissioner of the New York State Office of Addiction Services and Supports. And so she was in the room as a policymaker, able to contribute to the narrative, but also she was there to hear some of our concerns from a researcher's perspective. And so oftentimes I know that is really rare, but that is a passion of mine, and I want to continue this line of work so that our evidence can make real world impact. So now I'm gonna I feel like I've talked a lot, but I'm gonna transition a little bit to the K. A lot of my work will continue to fill in the gaps when it comes to not only just like polysubstance use, but thinking about how do we intervene from like a community perspective or policy perspective. And I plan on leveraging my K so that I can continue to build my program of research and as I move forward independence. And so as part of the summary statement, the application was described as having high impact, and it noted that the research plan was strong. It noted, the reviewers talked about like that it came from a strong candidate, but what really stuck out to me is that it says, if successful, her work will not only save lives, but reduce the broader social impact of substance use. And as I said earlier in the presentation, that was the whole goal of being here and being a substance use epidemiologist, was to make that impact so that people like my brother would not lose their lives unnecessarily, right? And so I'm very excited to have such an amazing scientific team to help me be able to accomplish the goals of the work. And so the K is really going to focus on informing some of the current gaps in the literature. So for example, understanding the transitions, how individuals transition across different profiles of polysubstance use, because we see that a lot of times someone may start with a specific profile, but they change over time, right? And so it's very critical that we identify some of these subpopulations so we know when and where to intervene early on. Also understanding which typologies are at increased risk for fatal overdose as well as all-cause mortality, and also developing a machine learning risk prediction algorithm to identify people who use drugs who are at the highest risk of an overdose episode. So again, I'm showing my amazing mentorship team for the K on here, and I plan on using the Ad Health study to answer a lot of these questions here. So now a little bit about mentorship. I have spent some time showcasing a lot of my mentors and collaborators, and because mentorship is important to me, I realized that I wouldn't be where I am today if it wasn't for a large body of mentors that have supported me throughout my whole trajectory. And one of the quotes is from Congressman Hank Johnson that really speaks to me. It says, "I'm standing on the shoulders of giants who knock down the barriers to opportunity, who knock down the barriers to exposure, who knock down the barriers to living the life I've imagined for myself." And so this has been one of those quotes that really sticks to me, and I've been engaged in mentorship since my the predoctoral journey at Hopkins as well, where I was a PhD mentor for master level students, and I mentored over 10 students within the Department of Mental Health. But also when I came here to Columbia, I also started mentoring students as well, because I wanted to give back to our community, but also be a part of the journey of the new incoming epidemiologists that's coming into the field. So I'm just highlighting 3 of my mentees here. We have Jinseo David Lee, who is a master's student over at the Morningside campus, and I'm advising him on his thesis where he's leveraging structural determinants to look at respiratory illness. And I also have Anise Brown, who I mentored back at Hopkins. She earned her MHS and she's currently preparing her medical school application right now. But a lot of our work really and we published together as well, focus on looking at structural determinants in COVID, especially during the 2020 epidemic, to see like if mobile home clinics were very efficient within neighborhoods that were particularly deprived. And so we've done some work in that space together. But I also am mentoring Gabrielle or Gabby Zuckerman over at UPenn as a PhD student, where she wants to leverage social determinants of health. Particularly right now, she's looking at gentrification and overdose risk as well. And I'm mentoring her with my colleague, Elizabeth Nisoff at UPenn. And so a lot of my mentorship and teaching centers around diversity, equity, inclusion, and justice, which I know are fundamental tenets within not only our university, but also within our department as well. And so I take an approach of like a student-centered active learning approach, realizing that students come to our department with various, past experiences, as well as a breadth of knowledge as well. And so a lot of times they need us as faculty members to just help them engage with the material a lot more so that they can go out in the world and be productive public health leaders, as well as efficient epidemiologists. And so that is the core of like thinking about how I view teaching as well. And I do have experience teaching as well. So like I would be very well equipped to teach any of the EpiMethod series, substance use epidemiology, social epidemiology, and structural determinants of health. And some of my past experience, I've TA'd over at Hopkins on the substance use epidemiology and related problems course with Renee and Johannes, also the social epidemiology course and our public health and good life course. And I've also been invited to guest lecture Dr. Piamardo's class here in the spring 2025, looking at epidemiologic challenges in substance use research, as well as Liz's class in UPenn, where I will be a guest lecturer as well, talking about polysubstance use, the overdose risk, and injection use as well. So with all of that said, I want to end with my mission statement and say that this work cannot be done in silos, right? It takes a community of community leaders, of researchers, and public health advocates, so that I'm really excited to continue this body of work with all of you at different intersections of outcomes as well. And so with all of that said, I want to acknowledge and thank my amazing funders, as well as collaborators, my mentorship team, as well as my SATEP mentors, and my fellow trainees as well on the mentorship team. And special thanks to Lisa, Amy, and Anna, who were instrumental parts of my whole journey here. So with that said, I am open to questions. I see something in the chat.
I think that is a comment from Yanis.
Oh, okay. It said, if I have been able. Okay, I'm gonna read it out loud. It says, if I have been able to see that far, is because I stand on the shoulders of giants, which originally said by Isaac Newton. Okay, so it was, I knew it from Congressman, okay, but that is really great to see. Okay.
I have a question.
Yes.
Thank you so much for that presentation. My question is, I've seen discussion among substance use epidemiologists and injury specialists around, some of the changes in overdose dynamics being a function not of policy actions and not in, there's been this big push for distributing naloxone, like this big push for overdose prevention. And the argument I've seen, and don't know if I agree with it or not, so I kind of wanted your take on it. But it's an argument I like because it fits with my own research program, is that there's a really strong cohort effect going on. And so you have that changes in the dynamics of overdose and opioid use disorder that are occurring now is because an older generation, that we had this certain generation that, opioid use just really ripped through the community like wildfire. That generation is now aging, and the new generations coming up are using different drugs and using them in different ways. I wondered if, I didn't see a lot of discussion of cohort effects and age effects in your presentation, so I wanted to see what you thought about that. And on the other hand, it's a pessimistic view because it suggests that the policy levers that we've pulled so far for the overdose epidemic haven't really been that effective. Your thoughts?
Yeah, absolutely. Thank you for that question. So I'm going to answer that question two ways. So one example I'm going to use is like Philadelphia. Currently, back in January, there is like conversations to pull back on harm reduction in Philadelphia. So that means like less certain service programs, less naloxone. And so in the next few years, we can only imagine, right, how that's going to increase overdose deaths among communities that really rely on some of these services. And so taking that, yes, I do think that having a cohort effect that could possibly be one of the explanations that we've seen as throughout the transitions of the overdose epidemic, but I think it's multifactorial and it's not all there because even within Black communities, we see that a lot of deaths are occurring amongst Black older men as well, right? And so, and again, we see that the different substances that they use shifts over time. So for example, heroin has definitely decreased over time. And you can argue, well, is it because people have died? The people who use heroin have died over time? Well, maybe, but also we know that the drug market shifts. And so people will use substances to alleviate some of the withdrawal effect based on what is available as well. So we're seeing by leveraging, for example, I know Joey Palomar has leveraged like drug seizure data, and that's one of the reasons I'm curious about to see if we can utilize these seizure data to see any effects in the overdose risk, especially across different communities. Because if you have heavier policing in an area, right, maybe they do a big, like for lack of a better term, like a drug bust, right? The individuals within that community may start using, maybe if they were using fentanyl or heroin, they might start using fentanyl. Fentanyl is cheaper, right? The half-life is a lot shorter though, so they might have to use a lot more and buy a lot more over time. But again, like I think when we're thinking about the cohort effect, I think as part of it, but I don't think that's the whole picture. I think that we need to take more of a multifactorial perspective when it comes to that. But great.
Yeah, I agree. It was a great presentation. And I think my question kind of comes off the back of Carrie's a little bit because I think, the other thing that we're hearing a lot about is this, being the first time we're actually seeing a potential reduction in overdose deaths this year. And I think a lot of conversation about, is this a true reduction? And if it is true, what's responsible for it? And I'm just kind of curious, I think, in that same vein, when you see those numbers, do you think, is this the success of our policy levers finally taking action? And so I guess kind of, because it feels like it's like a real sudden and dramatic shift. I'm just kind of curious what your thoughts are on that.
That is an amazing question. Thank you for that. So yes, we have seen within like the past year or two, we've seen that this tick down, right, when it comes to overdose risk. But this is where I'm really interested in leveraging the new mortality data and taking more of an intersectional perspective, because is that shift down, is it equitable across all subpopulations, right? Or is it just a result of like we're seeing some of the policies and the treatment in certain areas that might be more helpful towards, for example, white males, right? But may not have access to those for Black males. So within our recent study, we did see that there was a huge disparity, and we see that Black males are having these high risks of overdose at nearly 60% higher than their white males. So I think that within that downtick, part of me, and I feel like it might be superficial and more of an artifact rather than a true down reduction across all populations. And so this is where I'm very curious to leverage the mortality data, and then to look at that from an intersectional lens, but that's a great question. Yes.
We actually have another question in the chat.
Okay. Yeah, sure. Okay.
I can read it out. I would be curious to know what's the contribution of the medical industry in promoting substance abuse, either through prescribed painkillers, for example, OxyContin, leading to heroin use and abuse, for example, or recently, cannabis legalization, but also the pushing of, quote, behavioral drugs for ADD, depression, gender identity confusion, etc. Do you think this nexus could be uncovered by your research? And if not, do you have any ideas of how we can examine that connection?
That's a great question. So we do see that within the first wave, it was very much dominated by prescription opioid, right? And we saw that a lot of the medical community is with the narrative that OxyContin and Percocets, those were not addictive, right? We also saw definitely a prescription disparity when it came to the prescription of these drugs as well, where they were more likely to be prescribed to white populations, where amongst more minoritized populations, we saw that, there was this narrative that people are just coming in, they don't really feel pain at the same rate. So there was this huge disparity early on, and we would attribute the first wave of the opioid epidemic to the medical industry. As we move forward, there have been policies in place to help curb that, but we also saw the consequence of that, right? This unintentional consequence where now we saw that it transitioned to more heroin use during the second wave because people couldn't really get medication for real pain. And so that also speaks to how we're conceptualizing pain and how we're addressing it and these real concerns that people have from a medical perspective. But when we think of ADD, and let me see the second part, pushing behavioral drugs for ADD, depression, gender identity confusion, with that kind of work, yes, I do think that I would be more than happy to look at these different intersections. I realize with sexual gender minority, that is oftentimes a subpopulation that falls to the crack, and because we don't have a lot of great data as well, right, to look at this kind of work. So it would be interesting to look at it from there, but also realizing that we want to be mindful when it comes to using stigmatizing language and creating a narrative that might be stigmatizing, because ADD, depression, these are real, like mental health issues that people do struggle with and do need our medical system to be able to appropriately address. But at the same time, being able to be mindful when it comes to substances, because we put our trust in our medical care, right? And we know that's far from perfect. So being able to uncover these nuances using maybe like newer methodologies, or even older epidemiological methodologies, I think would be a very great next step. And if this is Giannis, if this is an area of a work that you're involved in and wants to collaborate and talk more, I would be more than happy to connect with you. I think this is very interesting. Okay, I see a second question as well. It says, I was extremely dismayed to hear that you take for granted that we will have a new generation of substance users and abusers with all the trauma that brings to the societal fabric. What would you say we will do about eliminate this scourge from our society? Is it by reducing the drug trafficking and supply lines? Is it by enforcing more strict punitive framework, or should we focus only on the treatment of problems? So we've seen this narrative of taking more of a punitive stance across from even the Nixon era. We've seen how detrimental it has been to our society as a whole. So when it comes to taking a punitive stance, I don't think that's the right framework to address this current overdose crisis that we have currently. Because having people go to prison is not helping their problems. That is not an outcome that we want. But I do see that there is shifts within our, in our drug supplies. We've seen increases in these like novel psychoactive substances. So for example, not only just xylazines, but we've seen increases in nitazines recently as well. So again, as our as we create these mechanisms from a policy, especially from a punitive standpoint, where we are just focused on getting these drugs off the street, and I put that in quotes, that is where it's just gonna be replaced with more novel substances. And history have shown that, like, this is not new. So realizing that we need to take more of a community health approach. We have different frameworks, especially when we look at Amsterdam, or even, for example, in Vancouver, Canada, some of their methods and their approaches have been, they are a lot more ahead of us than we are when it comes to the overdose crisis. So part of it, we should be thinking about legalization. What does that mean? Thinking about safe consumption sites. So within the Polysubstance Use Symposium recently, we had people from our New York City overdose prevention centers come and really speak about how effective it is and efficient to have these centers within our community, how they've reduced so many overdoses that would have led to fatal deaths, right? And so this is an area that we need to not only pour more research in, but also think about bringing more of our collaborators within this space as we're doing some of this work. So I'm gonna pause here and take Jeanette's question.
Yeah.
I see another one come up.
Yeah, so you talked a lot about integrating data science methods, and you know, don't have results for your NLP stuff yet.
Yeah.
But I do think it's interesting because, you know, this idea of integrating data science into epi grows and grows. But things are changing. There's cohort effects. And so when you talk about things like social media, we're in a place where we're shifting from text-based, people use Twitter, which I don't use anymore, to more short form videos. And that requires like totally different technology. So I just wanted you to talk a little bit about that from your own perspective of like, how does epidemiology keep adapting while still sort of, you know, we're not going to become technologists, but how do we shift? You know what I mean?
Yeah, absolutely. So currently, we see that within the evolving technology, one, we are seeing current challenges with like different policies around like APIs and whether or not you can even access the data. So that's one area of work and challenge that I feel like we're, as researchers, we need to kind of overcome. What before, even when it came to web scraping, it was pretty easy, but now it's a lot more challenging. But as time evolved, and seeing how people are talking and feel comfortable leveraging some of these social media and these communities, online communities, to talk and get advice and figure out like if they're using a new substance, they actually leverage social media to get advice in terms of how to do it safely, right? What's the dosage? And so we're seeing these narratives where as researchers, we can leverage it to say, okay, here we're going to be able to tailor our harm reduction strategies a little bit more efficiently so that we can address the real concerns from the people who are living with these lived experiences. So as epidemiologists, I don't think we're all gonna be data scientists and just all of a sudden do a lot of technological work, but I think through collaborations, we can increase our efficiency, right? Because we, from a methodologist perspective, we know how to be able to not only design these studies, but also do it in a way where our results are translatable, right? But from a data science perspective and some of my colleagues, I realized that they have a lot of the data science approaches down pat, but maybe they're missing that piece. And so through collaboration, I think we can make real world impact. Definitely cohort effect, especially when we see like, for example, Facebook, who's like my mom is on Facebook, but we've seen that the technology is progressing so rapidly over time, and sometimes it feels like it's developing faster than we can keep up with. And so with TikTok, we're seeing more of like the younger group, right, who are starting to engage in substance use and engaging in some of these novel combinations that we're not really aware of. And so again, I think this is an area that we can start intervention early. We can see what's going on so that we're not just describing the problem 10 years or 5 years or even 2 years after it has peaked, but we can start seeing it very early on and start shifting our approach to addressing it.
So are there any other burning questions? Maybe one more and then we'll end.
Perfect. I have more of just like a comment. I think substance use is like a really stigmatized behavior, and I think it can cause really emotional and divisive reactions sometimes. And I just want to say that I'm really grateful for the ways that you really humanize this work and approach it with such compassion and understanding. And I just wanted to like just comment that out. And I'm really grateful for all the work you do.
Thank you so much. Okay, so thank you so much, and I think
Meeting with people today, right? The least crazy. The least. Oh, right, I remember that. The informal- that's correct.